Okay, I think we're going to get started. So for anyone who might not know me, I'm Paul Orchard. I'm in the bone marrow transplant group. And I have the pleasure of introducing Dr. Jones. But before I do that, I just wanted to mention that, so this is the 16th Crivet Lectureship, and especially for the younger people that may not have known Bill, because we lost Bill, I think, in 2005. So Bill Crivet was kind of an institution at the University of Minnesota. He helped in the field of hematology, oncology, and coagulation. Published a number of very important manuscripts. Was a leader in the development of what's now the Children's Oncology Group, and was, like I say, a fixture here. He was the head of the department for a number of years, 80s, I think. And but the thing that he was most remembered for is the use of hematopoietic stem cell transplantation for lysosomal diseases and peroxisomal diseases. And so we have a lectureship every year, a memorial for Bill. We invite the outstanding scientists in the field. We have the opportunity to have Dr. Jones with us today. And Dr. Jones is from Manchester. He's a geneticist, I think, in my view, one of the premier geneticists in the field of lysosomal diseases. And we had an opportunity to work with him in the past, but never had him to Minnesota. So we took the opportunity to bring him here this year. So we look forward to Dr. Jones' talk.
Thanks very much, Paul. Thank you, Paul, for inviting me here to Minnesota. I've never heard you be so nice to me. I'm slightly worried by this. It unsettled me. It's a real pleasure. I've known folk from Minnesota for the last 12, 15 years that I've been involved with lysosomal storage diseases. And you don't do anything in this field without meeting folk from Minnesota. And because of long-standing collaborations with our centre and folk here in a number of different disciplines, I've had the pleasure of working, talking with, drinking with, publishing with folk from this institution for a long time. And so it's lovely to finally be here as well, and nice to see you're into an amazing children's hospital, and I look forward to having a look around later on. So it's a real pleasure to be here to give the Bill Crivet lecture. I'm not a transplanter, I'm a paediatrician who works in biochemical genetics, so I'm fairly unqualified to give the talk. But we work very closely with our bone marrow transplant group, because bone marrow transplant offers some of the patients that I see, I think of them as my patients, that offers them a tremendous change to their futures. It's a tremendous therapy for many diseases, but not all. And one of the interests that our group has had, and long-standing discussions with Paul, with Chet, with others from here about why transplant works in some lysosomal storage diseases and not others. And so thinking about some of those thoughts hopefully will lead us to better therapies. So the talk I was asked to give was about novel therapies for lysosomal storage diseases. About half my time is spent as a clinician. I work at the Children's Hospital in Manchester, UK. I'll maybe mention that towards the end of the talk. We are a pretty big children's hospital. We serve a sort of greater metropolitan area in the northwest of England of maybe 10 to 15 million people, depending on where you draw your cut-offs, and we're the main children's hospital in that area. So we're pretty busy just from a clinical perspective. We have about 300 kids with lysosomal storage diseases that we see. I also see all other inborn errors of metabolism. But about 50% of my time will be spent on clinical research, working with our university group on translational studies. And so there's lots of new therapies on the horizon or in early phase clinical trials for LSDs. And so I could have sat here and I've stood here and give you a list of those different therapies and whether they're worth backing or not, and the various problems. But actually, when I think about many of those new therapies, the problems, the challenges, the questions we have are mostly related. They're not new questions. They're actually the questions and the challenges and the problems we have with the therapies that we've had for the last 10 to 20 years. And so if we can understand why our old therapies work or don't work in some situations, then I think we've got a much better chance of bringing in all of our new therapies. There's a raft of gene therapies about to hit or actually hitting the clinic. But I really don't think we know how to use those. And all the questions that are emerging now about actually moving from a mouse to a human, those critical questions, I think if we understood the therapies that we've had for a longer time, for the last 20 years, I think we'd have a better idea how to use those gene therapies and bring them through to the clinic in a better way. Okay, I'll stop waffling. That's my disclosures. I've worked with most of the companies in this area because I think that benefits my patients. So there we go. For the hematologist there's a blood film. So we're talking about lysosomal diseases. So monogenic disorders, genetic mutations in a gene lead to a deficiency of an enzyme. The enzymes, hydrolytic enzymes within the lysosome that degrade complex molecules. And so you lack those enzymes, there is storage. This may all be, and is likely to be, very old news to you guys in Minnesota who are very familiar with lysosomal storage diseases and will probably see more of these children than in many hospitals throughout the US. But that's the principle. You lack the enzyme, you accumulate the substrate of that enzyme that accumulates within cells, and somehow, we don't really understand this bit, that causes disease. We like to look at things under the microscope and say, well, that's why the cell doesn't work, but we don't really know. And depending on what the substrate is and where it's stored, so a Gaucher patient with massive hepatosplenomegaly, that determines the clinical disease. So there are over 50 lysosomal storage diseases, and if you're a paediatrician who looks after these patients, then you've got to be a jack of all trades, as you would say in the UK, and very much a master of none. You have to deal with multi-system disease and work with many different specialties. So we have another example of a lysosomal storage disease, in this case very different, not visceral storage as such, but muscle storage of glycogen in an infant with Pompe disease. So we've got a progressive neuromuscular disorder. But perhaps the paradigm lysosomal storage disease, one that affects almost every tissue cell in the body, is Hurler disease, Hurler syndrome, MPS type 1, mucopolysaccharidosis type 1. And many of you will be very familiar with these patients because many of these patients come through your transplant unit and through your genetics department. This is a slide I like to show because I like to remind our juniors and our trainees when we're lecturing what these to look like. You don't see pictures like this anymore. I like to sometimes ask what decade you think the picture was taken in from the wallpaper, and that's, you can probably hazard a guess. It's not all houses in England look like this. So we don't see untreated Hurler kids anymore. We haven't had a family refuse bone marrow transplant or not have a donor for well over 15 years. So we don't see this as an untreated Hurler patient. We simply do not see this anymore. And when people look at our outcomes for bone marrow transplantation of this disease, they see patients who are not cured. They see patients who have some learning difficulties, patients who still have some significant bone disease, patients who are shorter than average, patients who still have some deafness. And they think, well, this is a rubbish treatment, isn't it? And that's because they've never seen these guys. And so this is a girl about the age of 7. And you can see almost every part of her body is affected. She's got significant skeletal disease, bones, joints, soft tissues, everything. She's got cardiac valve disease and may have cardiomyopathy. She's got an airway that, if you're an anesthesiologist, you don't want to go near. It's the worst possible airway there is. There's a textbook of pediatric anesthesiology which states, the MPS children are the worst children that you will ever anesthetize, as a kind of a warning, stay away. And so this child also has progressive neurological disease. She will have reached her maximal developmental attainment at around the age of 3. She won't have been equivalent to a 3-year-old, however. She will have plateaued for a while and then declined. So, very significant disease that affects all parts of the body. Why do we think we can treat a disease like this? Why on earth do we think we can treat this? And this is an example, a cartoon of how a normal cell will make lysosomal enzymes. So these enzymes, assuming there is no mutation, are modified in the Golgi, the ER and the Golgi. They're glycosylated with a mannose-6-phosphate tag that will ensure that those enzymes are trafficked to the lysosome. These enzymes, in general, only work at the acid pH, and so only are functional within the lysosome. And for some reason, I'm not sure we fully understand it, Chet may disagree, but I'm not sure we fully understand it. There is a biological system in place where about 10% or so of these enzymes made in a cell are secreted and end up outside the cell. So they're appropriately labeled. They should have gone to the lysosome, but they didn't. They're outside the cell. They're exocytosed. And because they have the appropriate mannose-6-phosphate tag on their surface, because most cells express the mannose-6-phosphate receptor, those enzymes can be taken up by the cell and will again be trafficked to the lysosome where they can become functional. And this process of secretion recapture allows us, it's a biological normal mechanism that allows us to potentially deliver enzymes to these patients. And in essence, all we have to do is get the enzyme near these cells, and in theory, they should end up in the lysosome. That doesn't happen for my patients with mitochondrial disorders or my patients with peroxisomal disorders. You could make the recombinant enzyme that those children are lacking, but you can't get it to the right place in the cell. You can't get it to the right place for it to become effective. So this mechanism, which is already there, we can hijack. So either by administering recombinant human enzyme to these patients to the bloodstream, getting it near enough tissues, using the blood as a way of delivering that enzyme to cells and to tissues, it would be taken up and end up inside cells, degrading substrate. But we can also use it in bone marrow transplantation. In bone marrow transplantation, I like to think of it, I apologize, Paul, as a crude form of gene therapy. What we do is we replace just a subpopulation of cells. Right? So we correct the genetic defect in a subpopulation of cells in the body, the bone marrow-derived cells. Those cells express the enzyme. Those cells traffic around the body, including to the CNS. They secrete the missing enzyme because the donor doesn't have Hurlers, the donor doesn't have an LSD, you hope. And they secrete the enzyme, that enzyme is taken up, and so you correct the defect, the cross-correction. So, long-winded, but important model. So, where are we now? We have enzyme replacement therapies, recombinant intravenous enzymes for these now licensed therapies for this range of different lysosomal storage diseases. These are usually weekly or alternate weekly drugs given by a slow infusion over a few hours. And most of these drugs are given, at least in the UK, as home therapy and are lifelong therapies. They've changed the lives of many of these patients, but none of these therapies are a cure. We almost all have residual disease, perhaps with the exception of type 1 non-neuronopathic Gaucher disease. So we have dramatically effective therapies, but these are not cures. And in none of these preparations does the IV enzyme cross into the brain and correct the neurological disease. And that's why, at least at the moment, we still need Paul and bone marrow transplant teams. So I'm going to think a bit more about MPS diseases as a real paradigm for thinking of how we develop therapies and how we and looking at our outcomes from treatment for LSDs. So a complex slide. What we aim to show, there are many different MPS disorders, all caused by an enzyme defect that leads to an accumulation of substrate. HS is heparan sulfate, DS is dermatan sulfate. If you accumulate heparan sulfate, primarily, you will have a disorder which will involve probably your brain, and you will have at least a neurological component to your disease. If you have dermatan sulfate storage, primarily, then you will have skeletal and somatic disease, whereas if you have a combination of them both, you will have a mixture of somatic and neurological disease. We're thinking about MPS 1, like all of the lysosomal storage diseases, a spectrum. The severe kids, nonsense mutations, no residual enzyme, rapid accumulation of substrate in all parts of the body. You saw the last picture and this is called Hurler syndrome. Residual enzyme activity, slower accumulation of substrate, relative but not complete sparing of the brain, and you have Hurler-Shea and Shea disease. These kids are on a spectrum, and we treat the Hurler kids, because they've got neurological disease, with hematopoietic stem cell transplantation. And the kids who don't have so significant or progressive CNS disease get our recombinant enzyme, because we think we don't need to get to the brain. So we've got 2 established treatments for disease, which is already a challenge when we think of developing new treatments. Where's the room for them? How on earth do we study a new treatment when we've already got 2 standard of care treatments for a rare disease? So looking at IV enzyme replacement therapy for MPS I, we published recently on long-term follow-up in about 35 Hurler-Shea children, so children with the attenuated form of the disease. And we see that very easily we can reduce the urine glycosaminoglycans, and we always like to show percentage drop. Of course, none of them are actually normal, but we significantly reduce GAGs in almost all patients. We stabilize what would otherwise be progressive respiratory disease, obstructive and restrictive. We can make them walk better, or at least they don't get worse over time. There's a multi-system disease where they become progressively impaired. And we see that for most of our patients, that's stable, so they don't get worse with time. Now, the different groups, the grey line at the bottom here is the older patients, the patients who started therapy later than the younger patients. And you see that the older patients who should walk further than the younger patients walk less, indicating that they're more impaired, progressive disease. But in all patients, or most of the patients, we get stability with long-term intravenous ART. But there's maybe one patient at the bottom, that black dot out at the very end, who's a bit different. And as time goes on, you see our standard error bars increasing. That's not just because the numbers are smaller, but because there's a variability in response. And when we look at height as a proxy for skeletal disease in our patients, we see that the standard errors are even greater, and that the variability in patient response is significant. So this is standard deviations. If you're growing normally with a normal growth velocity, you'll have a straight line. You see, most of these patients are relatively straight on treatment. It's a progressive disease with a progressive decline in growth velocity over time and significant short stature in the end. And so untreated, there's no control group. This is a retrospective study of our own patients in clinical care. These patients should have a declined Z-score every year. And you see that the older patients are shorter. That's not that they get smaller, but shorter in terms of Z-scores. But again, there's significant variability. So we do have an impact on skeletal disease, which has traditionally been very difficult, but it's not perfect. They don't show any catch-up growth, so those patients who are -4 or -5 don't become normal with treatment, but they stay where they are. So growth velocity improves, but it doesn't normalize. There's no catch-up. And there's significant variability. And again, this patient at the very end, the black dot, is a patient who we treated the same as everybody else, who was a patient who was treated very young, under the age of 4, who had the same dose of the drug as everybody else, had the same compliance, but showed almost no response. So what factors influence variability? You've seen already from some of our retrospective data, just from our center, that patients who are treated earlier do better. This is a family where the index case, the girl on the left, she was diagnosed at the age of around 5. This is a family with attenuated MPS I, Hurler-Shea disease, a very well-known mutation we see quite a lot in the British Pakistani community, and leads to a fairly significant skeletal disease. So she, after 1 year of treatment from 2007 to 2008, had some improvement. She felt better, she walked better, but her joint contractures weren't really any different. Her younger brother, who we diagnosed because we diagnosed the older sister, was 3 when he started treatment, and he has actually showed a better response. Again, same treatment, same mutation, just delivered at an earlier point in the course of the disease, and he was doing better already. But there was another sibling who was just born as we were diagnosing these guys, and here she is at the age of about 5 with almost no features clinically of MPS at all. She was treated from a couple of months of age. And there's many, this is by no means the only example of sibling studies showing how delivering the same treatment just much earlier in the course of the disease leads to dramatically better outcomes. She doesn't have hepatosplenomegaly, by the way, that's a north of England diet. But radiographically, she's excellent. Clinically, she's excellent. And she's had a much better response to the same treatment. So now many people look at my adult colleagues, when I hand over our patients at the age of 18, I'll go, what are you giving me? You know, some of these patients that we hand over are dreadfully sick. They're going to need heart valve replacements. I was talking to Liz Bronlin yesterday. They're going to need heart valve replacements. They've got terrible airways. They've got a terrible skeleton. But we treated them really late. And so there's now lots of questions being asked in the UK where we have a National Health Service and money is scarce. What about these really expensive therapies? Are they really effective? Well, we don't use them often in the most effective way because we're starting when a patient is symptomatic. And so if we were to start everybody at this point in life, then we may have a much better outcome for our patients. So early treatment is a major factor in response to the disease. Another factor, we think, might explain why this girl, the girl who is illustrated by the last black dot there, the girl who had almost no response. She started relatively young, but she had a very poor response. And we investigated her after about 10 years of ERT. It took us a while. We're slow. It took a while for the penny to drop. And it turned out that she had significant antibodies against the recombinant enzyme. That when we looked at these antibodies, we used her serum in our lab, looking at uptake into MPS I fibroblasts, we found over 90% inhibition of uptake of enzyme when we administered her serum. So she had significant neutralizing antibodies which impaired the efficacy of her treatment. It took us 10 years to work this out, which she will never get back again, and which I regret. We've had a licensed enzyme for MPS I since 2003, and I think we're only just beginning to work all of this out. So it's difficult. B, we're not helped very much by the companies, by others. It's very difficult to get funding for this kind of work. But we think it's important. It's not important for everybody. Again, a cartoon showing how this might happen. Antibodies that block cell uptake, antibodies against mannose-6-phosphate. But actually all of these enzyme replacement therapies have an alloimmune response. This is just published data, and you can see in this column here for MPS I, more than 90% of patients have some antibodies. Does that mean the enzyme doesn't work? No, of course not. We've shown it works in the majority of patients. And we've made the mistake, I think, early on of just measuring total antibodies and assuming that told us the answer. Whereas patients' antibodies are very different. So one patient's antibodies are different from another patient's antibodies, and they're polyclonal. And some of those antibodies, if they're high titer and are aimed at the right epitope, or the wrong epitope, if you like, will become functionally significant. And we've seen that in MPS I. We've seen it very clearly in Pompe disease, where if you're an infant who develops a high titer response, then essentially you die and you don't respond to enzyme treatment. And it may be an issue in many of these other diseases. But this, again, is, as I said, is difficult work. A messy slide, I apologize, but this is a group of 10 MPS I patients with Hurler syndrome prior to transplant. We measured their antibodies, and all of those patients, when they were exposed to the recombinant enzyme, had a pretty massive antibody response. Now, they're Hurler patients. They had a few months of enzyme treatment, and then they were transplanted as their definitive therapy. And so post-transplant, we stopped enzyme, and all of them had a tolerization. At least their antibodies went away. But it took quite a long time. So what does that mean for our Hurler-Shey patients who are on lifelong enzyme replacement therapy. Do they matter? So we work with the Dutch group who have some very nice biomarker assays, and we looked at their Hurler patients on long-term enzyme and ours, and they did some very nice stats and some very nice biomarker work and showed that those patients with antibodies that interfered with uptake of the enzyme into cells had a significantly reduced biomarker response to our enzyme treatment. But there's all kinds of argument. We could argue about biomarkers all day long. Is that really important? Sorry, I've cut off from my slide. But we looked at the same group of patients, again, our group in Manchester, the Dutch group who we work with, and they follow up the patients very similar way to us. And again, we could show that not just was there a decreased biomarker response in the presence of these antibodies that inhibit uptake, but actually the patients who had inhibitory antibodies had significantly more sleep-disordered breathing than our patients who didn't have those uptake inhibitory antibodies. So a significant clinical outcome. This has led us to wondering how we would manage this. So we're trying to develop now a search method for assessing antibodies to move that through to our clinical service. We've also tried to borrow from the Pompeii experience where we now have a relatively standard immune tolerance induction regimen using methotrexate and rituximab when we first give that enzyme for the first few doses of the enzyme. And in Pompe disease, that appears to induce tolerance long term. So we don't have to keep immune modulating. Those kids respond better. So we are now doing an investigator-led study at our centre looking at immune tolerance induction in MPS I and Hurler syndrome. Again, this is difficult stuff. The government won't sponsor it because it thinks the company should sponsor it. The company don't want to know. And so we have to get money from patient groups and do it as PhDs, etc. So difficult work, but important. And I mention this today not because it's just important for enzyme treatment, because it's also very important probably for gene therapy to come. So why do we transplant MPS I patients? So this is a very old slide put together actually by Elsa Shapiro, of course, of Minnesota fame, and shows one of the very early studies using IV ERT for MPS I. And it enrolled non-transplanted patients under the age of 5, both Hurler and Hurler. And you see the developmental age equivalent of the Hurler kids. So they reach a plateau very soon, whereas those patients who are Hurler carry on. So these are all patients who've had somatic treatment, but no neurological treatment. And transplant undoubtedly works dramatically. Our patient from earlier in the presentation, a guy with the same mutations, the same 2 mutations, at the same age, who's been transplanted successfully in our centre, but it could equally be one of Paul's patients, one of your patients. And you see there's a dramatic response. These guys are not the same. There's a dramatic benefit. The transplanted cells donate significant amounts of enzyme. But these guys almost all have some residual neurocognitive problems. And they have significant skeletal disease. They are almost all short, and they have often progressive hip and spinal problems. And so transplant's a fabulous treatment, but not a complete treatment. In the past, transplant was dangerous. The 2 lines here this is all transplanted Hurler patients from our centre, and I'm really showing this to show you what happened in the past. So before 2003, using old regimens, then the old line, the bottom curve, showed our percent engrafted survival. So it used to be about 50% of patients with Hurler would get through engrafted. So a difficult treatment. With new regimens, and I think the metabolic community can take very little credit for this, it's mostly been the transplanters who've made these improvements. From the metabolic community, I think we've hopefully added a bit better supportive care, and we've added some enzyme prior to transplant. But it's the transplanters working together, collaborating, combining data, and coming up with new regimens has allowed much, much better survival. And we recently published survival and outcomes, or transplant outcomes, from our centre in Manchester and here in Minnesota, showing since 2004, we've got now 88% overall survival. And I think when we look at since 2010, the figures are probably even better than that. And I think one of the reasons why we collaborated with Minnesota, not just because we get on with folk here, but again, it's important to show that this isn't one centre doing something better than everybody else. This is most of the big centres doing lots of this kind of work have got very similar outcomes. And I think that's important. And I think that the data sharing and the collaboration and the openness that there's been in general around this whole area has been a good model for many of us dealing with rare diseases, rather than one centre competing constantly with another centre. That approach has led to everybody getting better every few years. So I think that's been very important. So I've mentioned that patients are now surviving, but there's significant residual disease. What are the factors that influence that? So again, a big collaborative effort from some of the main metabolic and transplant centres across the world. A few years ago, we looked at almost 200 Hurler patients who've been transplanted and their long-term outcome. And so the key factors that influenced the cognitive outcome is how old were they when you transplanted. So that's not something that we can currently influence. The patients come to us when they come to us. You in the US are now starting newborn screening for MPS I. So this will change dramatically for you. It will give you new problems, because you're now going to have a whole range of babies and you have to work out what to do with them all. But I think I'd rather have that problem than the problem I have, which is maybe an 18-month-old sent to me after he's been bouncing around a children's hospital, seen by, 6 other specialties for the last year. So I'd rather have the new problem than the old problem. But again, one of the very important factors that influence how bad or how good is your skeleton, do you need lots of orthopedic procedures, was how much enzyme we delivered. And so this is important, and I think this has been very helpful in allowing us to think about the way forward. If you have a transplant from an unrelated donor who's not a carrier, then your leukocyte hyaluronidase level, the enzyme, will generally be in the normal range. And those patients do better long-term than patients who had a transplant from a sibling carrier, so who get approximately 50% less enzyme. And so we could make a strong correlation between the amount of enzyme delivered by the donor cells and the outcome. And so that led to lots of thinking about how we might approach gene therapy in this disease. Because if 2 gene copies are better than 1, maybe 4 or 5 would be even better than 2, and hence you get into the world of gene therapy. So how do we improve outcomes for the treatments that we've had for years? So we've talked already, earlier diagnosis, better enzyme delivery, better distribution. So we need to somehow get more enzyme into the bones. And how do we do that? Do we just give more? Do we change the enzyme? And when we take my orthopedic surgeons, when they take a chunk out of some of my patients trying to improve them, and if we look at that chunk of bone under the microscope, there's GAG there. It may be a very well transplanted Hurler patient with normal leukocyte enzyme level, but there's still a lot of GAG in their bone. We don't normally take a chunk of the brain, but I bet that isn't normal either. So how do we get the enzyme to hard-to-reach places? Well, we can get rid of antibodies. That would be a good start. We've achieved that with transplant because we transplant the immune system. But we don't yet know how to do that for ERTs. So adjunct of therapies, there's a whole range of new add-on therapies that we should be thinking about and starting about. And some of those trials have started. But I would suggest that we haven't a clue how to do add-on trials because we struggle doing trials for rare diseases where there's no treatment at all. We struggle working out what endpoints to use, what inclusion-exclusion criteria to use, and that's all so much harder when there's already a standard of care. We need to understand the role of biomarkers better. We've been measuring GAGs in the urine and blood and various tissues for years, and we still struggle to know exactly what that means. And we still struggle with our outcome measures. For the transplant guys, it's easy, he says. They have lovely databases and they collect survival and GVHD incidents and all of those things. And that's transplant outcome, and that's well collected and well studied and well published. But disease-related outcomes are really challenging. We've been using the same fairly rubbish, difficult tests for a long time. For 15, 20 years, I showed you a 6-minute walk test. What does that mean? We've no idea, really. There are so many flaws in that test for an MPS patient. And yet, whilst I could talk to you for an hour about why that's a rubbish test, I'm not sure I can come up with a better one. And so we still end up using it. And actually, outcome, and we've been talking about this with the team here, actually outcomes are not just affected by flashy new therapies, but actually by the really hard grit of long-term multidisciplinary follow-up and work that goes completely against the grain of how a children's hospital like ours works. So getting surgeons in the same room and talking to each other and agreeing on plans with physicians, etc. All those things which doesn't normally happen too easily. That's a real challenge in our children's hospital, I suspect in yours and in most children's hospital. It goes against the grain, goes against what we normally do. So how do we improve this enzyme delivery? So we can, if you're transplanting, you can improve the choice of donor. You can aim for full engraftment, and the conditioning regimens mean that that's almost always the case now. For IV treatments, we can alter the dose of the recombinant enzymes. Very little experience doing this, really, Gaucher disease. I don't know why we all use the same dose in almost every patient, with MPS 1, 2, etc., etc. We don't do that in diabetes with insulin. We don't do that in epilepsy. We don't do that in almost any other disease. Is it because it's very expensive? Maybe. But there are real challenges. Is it because we don't really believe our biomarkers? But we don't individualize. And then combination therapy. So if more enzymes better, why don't we give IV enzyme on top of the transplant? And actually, Paul and the team here in Minnesota have been doing that in a trial, which I think is very valuable. Or the answers, I hope, will be very valuable to the rest of the field, and we're grateful for that. And Troy, and again, the team here have been doing intrathecal enzyme replacement therapy on top of transplant or around the time of transplant. And again, ways of delivering enzyme better, trying to maximize enzyme delivery, get it in as early as possible and as much as possible. But of course, we're delivering multiple expensive, risky therapies here, which is even more challenging once again. Again, there are add-on therapies, both stop codon read-throughs, which are in trial in MPS 1. The same drug that's licensed for Duchenne, indeed. And substrate reduction therapies, which I'll mention briefly. Of course, the logical approach here, the rational approach, following on from what we said, 2 gene copies better than 1, why not 4 or 5? Well, that leads us to gene therapy. And where we all think we should be going, and where we've all thought we should be going for maybe 20 plus years, Ed Wraith, who founded our unit, who founded really in Europe, the way of looking after MPS patients before, if it ever was sexy, before it was in any way sexy to look after MPS patients. Maybe that's wishful thinking on my part too. But before there was any interest in looking after these patients in Europe, he would travel throughout Europe and establish clinics and see these patients. And he always reminded me, yes, we're saying to our patients, gene therapy is around the corner, but Simon, I was saying that 20 years ago, and it's a very long corner. So we are now actually in some early phase gene therapy experiments in many different parts of the world. But I think it's important to think there are so many academic groups who can do gene therapy in mice with lysosomal storage diseases, and there are actually very, very few clinical trials actually happening. And that tells us something. I think it should tell us something. That actually it's much easier to do something in a mouse with regards to enzyme delivery than it is in a patient. So I'm going to talk a little bit about gene therapy, but not too much. Paul's looking worried. So there are major challenges. There are many, many different ways of approaching the gene therapy model. And the fact that Many of these are being postulated and trialed either preclinically or in early clinical phase studies in the same diseases, in lysosomal storage diseases. Tells me one thing. It tells me we don't have a clue what the best way is. If we're trying 6 or 7 different ways, it kind of tells you we really don't know the best way and the right way. And it may be that many of these routes actually would work, or it may be that none of them would. So if we're treating neurological disease, or we need to treat neurological disease like we do for many LSDs, then the route of delivery and the choice of vector are probably very important. Systemic versus central nervous system. Again, there's many different ways you could administer vector to the central nervous system. All have their advantages, all have their disadvantages. This is all very new, exciting stuff, or is it? Or does it just come down to distribution and delivering enzyme to all the right places and the old problems that we've had for many years? Immunogenicity. So a problem that we've talked about with our enzyme replacement therapies, but still a significant problem for gene therapies. It has predominantly been thought about with regards to the immune response to the viral vector. So AAV9, for example, many groups' choice of vector because of its relative predilection for neurons, for the brain, makes a lot of sense, but 10-20% of kids have pre-existing antibodies, which is a challenge. And you may well not be able to, because of the immune response against AAV9, do redosing. And that's a problem for many, probably a problem for many of the AAV approaches. But perhaps of more interest to me is the fact that there's still likely to be an immune response to the expressed protein. No gene therapy yet will correct every cell. And the reason that the lysosomal storage diseases are such an attractive group of disorders for gene therapy is because you don't actually have to correct every single cell to treat your patient, because there will still be secretion and recapture. If you overexpress your enzyme, then you'll get significant delivery to many cells if you only correct a few. But you then end up with the same issues of immunogenicity. And again, if we can't crack that and understand that for recombinant enzyme therapy, how are we going to crack it and understand it for gene therapy? Well, you've got one shot at this. And you get it and you get it right, or you don't. So the old problems of who do you treat, how early can you treat, and how early do you need to treat that we have with transplant, that we have with enzyme treatment, are exactly the same problems that we will have with gene therapy approaches. No matter how good they are, you'll still have to treat the patient early enough in the course of the disease to stand a chance of that child benefiting. So you have to, A, be able to diagnose early, and B, know what early is and what early isn't. And I think our view of early treatment has changed dramatically. I think mine certainly has over the last 10 years. We used to think for many of these disorders, starting under the age of 5 was glorious and wonderful. And now we're probably talking about the first few weeks or months of life. There's lots of technical issues around ex vivo or in vivo gene therapy. So do you deliver the vector to your patient? Or do you do the approach which our group in our university has spent most time doing, which is that modification of bone marrow transplantation? It's not a new approach. It's not our approach even. It's been used in a number of different disorders. And it's taking a patient's own blood stem cells, modifying them in the lab, putting them back in an auto transplant. But with a lentiviral vector and a promoter that will massively overexpress the enzyme production. So you turn those cells into enzyme factory. Because you've done a bone marrow transplant, some will go to the brain. And Alessandro Biffi in Milan has shown this dramatically in metachromatic leukodystrophy. A horrendous neurological lysosomal storage disease where allotransplant has some impact, but it's not curative. And it isn't as good as you would want. And autologous gene-modified stem cell therapy has, in those patients, has left with almost normal patients. Now that's maybe 5 years follow-up. We need to see what they're like at 15 years follow-up. But untreated, those patients didn't have any more than 5 years follow-up anyway, because none of them were surviving beyond that. So that's a significant choice that we need to make. And trial design. What's the right trial design? How do we do it? How do we randomize? What control groups do we have? And how on earth are people going to pay for gene therapy? Maybe more of an issue for us in the UK. Maybe America is so wealthy that you're okay and there's no problem. But I think it's a significant issue here for different reasons than it is in Europe. But these therapies are expensive, and a therapy that costs £1 million, perhaps for a one-off lifetime therapy, well, you can argue that makes significant savings over 10 or 20 years. But actually, someone's got to pay it up front. And that argument of you might save money in 5 or 10 years' time doesn't go down very well, not in the UK. So whilst it kind of conceptually makes sense, the reality of it's pretty hard and difficult. So quickly, I'm gonna run out of time soon. I was gonna talk briefly about Sanfilippo disease, but I'm probably not going to, because I'm gonna run out of time, and I will talk forever about Sanfilippo, as it's a passion of mine. So I'm gonna finish up here by saying I think we've come a very long way in treating children with lysosomal storage diseases. We have significant unmet need, the bones, the skeleton, joints, and the brain. And the new therapeutic approaches, we hope, will offer a step change, will offer us the chance, the ability to do something that we can only dream of at the moment. But actually, I don't see that when we get to the nitty-gritty. We're sitting now trying to design our first-in-human gene therapy studies, and we've got all the same problems that we did when we were doing the early ERT studies. Who do we pick? What's the inclusion-exclusion criteria? What's the right kind of patient? How do we do safety monitoring? What on earth are the endpoints going to be? And we worked with a lot of folk from here and from many other centres in a meeting in London last December, where we all agreed as a community, academics, clinicians, even with some industry involvement, and FDA and EMA were there on consensus guidelines for what we measure in neurocognitive outcomes in the MPS disease. So we're trying to come together and agree how we measure, what we should measure, how we do this, but it's very challenging. I think the old difficulties that we have will remain and are not yet solved. And if we can't solve these issues for ERT and transplant, how are we going to solve them for gene therapy that we're only just scratching the surface of beginning to understand? Distribution of the enzyme, delivery, dose, early diagnosis. I think you're doing better in the States than most countries in Europe with regards to there's much more newborn screening here. We're still very resistant. Immunogenicity issues, and as I said, outcome measures. I want to acknowledge everyone in my centre who does the majority of work. Rob Wynne, who's our transplant prof, who, again, we work with very closely. We sit and we do all the clinics together, and that, I think, helps us all. Ed Wraith founded our unit, a very unconventional professor, sadly died 3 years ago, but really influenced how we look after these patients and how we think about these patients. And I want to thank everyone here, Paul, Troy, everyone in Minnesota, for the pleasure of being able to work with you all for a number of years. Hopefully that will continue. And we've talked a bit in the last day or two about new ventures and new collaborations. So I'm very grateful for you all to invite me here. I want to just finish off. I come from Manchester. Our children's hospital is 2 miles from where the bomb hit on Monday. And all the kids came to the RER. Our physio on our LSD team, her daughter was at the concert and was okay. But I'm not sure if anyone's going to be okay really following this. So perhaps just, I think the mood of the city is somewhat defiant. We're carrying on. A lot of concerts happened the night after the bomb. And thank you all for your solidarity and your support that I've had over the last day or two. Thank you.
Thanks, Simon. Questions? Sure.
Thanks for that terrific talk. That was really outstanding. Thank you for being here under difficult circumstances. Okay. Certainly send our best to your community and in our thoughts. I wanted to ask you about the antibody response to the recombinant therapy, the recombinant enzyme, and just very simple terms. Why don't we all make an antibody against our own enzymes? Is it something about the way the antigen is presented, the recombinant systems that are used, the depot for delivery of the compound? Immunologically, how can we explain this?
Yeah, I think there's short answers and there's long answers to that question. It's a very good question. So I'm not an immunologist, but I've had to delve into that world in the last sort of 5 or 6 years while we've been trying to work through this. It's and the deeper you scratch into the issues around tolerance, issues around what is viewed as self and not self, and foreign antigens or self antigens. That's not, to me, at all very clearly understood. I've discussed it with a lot of immunologists, and I don't think the mechanisms are fully worked out. But clearly, if you are not an MPS 1 patient, if you are not a patient, you're not deficient in the enzyme, then you will express that enzyme from in utero and beyond. And so the standard approach of education, presentation, etc., in early life, either late fetal life or early postnatal life, allows generally a tolerance to that enzyme. That's the received wisdom, I guess. So you would predict that post-transplant, again, you've got a wild-type immune system which secretes the enzyme, then you shouldn't get antibodies. But I'm not sure that's entirely the case. And I think your issue around is the recombinant enzyme exactly the same as the native enzyme? Well, that's, it may have the same amino acid sequence, but that doesn't mean it's the same. And we also deliver it as a bolus, a weekly dose to the body as a bolus, over 4 hours. And so that clearly isn't terribly physiological, and that may have significant implications, if there's aggregation in the bag, then that's quite an immunogenic thing. So we know that patients who have nonsense mutations, who express no endogenous protein at all, so the CRIM-negative patients, then they are much more likely to have a robust immune response than those who don't. But we have a number of patients across a range of diseases who must have quite a lot of residual enzyme activity because they are a slowly progressive patient. And they can still develop really quite a significant immune response.
So just to follow on that, as an immunologist, I would predict that if the enzyme replacement or gene therapy were to start in the neonatal period, that the likelihood of tolerance induction would be greater than if it were started later.
Absolutely.
Is that known?
Kind of. I mean, it's absolutely a good question. What's the window? I've asked many folk like yourself, what's the window? I think we might know what that is in a mouse or a dog. The best way of tolerizing the MPS 1 dog isn't to give it a whole pile of immunosuppression, but is to expose it to a small amount of IV enzyme from the first day of life. And then you could do almost anything later on. So you're right, there may be a window. Quite where that is in the human, we don't know. I had a very premature patient with Hurler syndrome diagnosed, was born at 28 weeks gestation, and we started enzyme treatment not at birth, but before the child's sort of due date, expected date of delivery, and that patient, despite having been CRIM-negative and nonsense mutations, had a much, much lower antibody response than you would expect, than our other patients who had that mutation had. So there's probably something in that. There's some experience in Pompe disease of, patients who started treatment at day 14 developed a more robust antibody response than patients who started, at day 2 or 3. Of course, we don't normally get that chance, but good questions.
Hi, Simon. I want to say thanks so much for coming, and what a great presentation. I frankly have heard no more detailed and articulate and comprehensive presentation of all the problems we face.
Yeah,
now that we can treat,
answers.
Now that we can treat Hurler syndrome and no longer have that old phenotype, much like PK disease. We don't see Hurler syndrome at all, period, anymore in the Western world. To follow on the immune studies, we have numerous experiments in mice where we tolerize mice with Hurler syndrome with enzyme from the get-go, and we get much higher expression of iduronidase enzyme activity after gene therapy. So, as you pointed out, early tolerization, like any other condition, will ultimately be successful. Thus, the importance of newborn screening. The other thought is that I want to let you know about a new article that's in press right now. Janine Jarnes and myself have just tolerized a patient with Hunter syndrome, one that many people in the audience know of, without rituximab, using small daily doses of elaprase enzyme. So that concept again is reinforced by that. But we're also facing, these other challenges that you mentioned, and for better or worse, I think tremendously for the better, we're starting newborn screening here in the U.S. In fact, yesterday I did a webinar to the laboratories in the U.S. describing MPS I, trying to educate them about the clinical aspects of it. And in Washington later on this summer, those laboratories are meeting, and I'll be presenting to them with the clinical data, the kind of thing you've showed, and the importance of newborn screening. One of the key questions that they're trying to answer that you might have some insight into is how do we differentiate Hurler syndrome from these later onset ones? As we start newborn screening, it's going to be based on deficient enzyme activity. And of course, we're not going to know clinically how those newborns are doing. Do they have Hurler syndrome, and do they have Hurler Shea syndrome, or even Shea syndrome? Or do they have the pseudodeficiency, which we described back here for the first time, 20 years ago? Before I ask you to answer that question, I got to say one more thing. Bill Crivet would be standing up here at the front of the podium saying, "See, Chet, I was right." You showed for the first time, I think, in that article, that homozygous donors giving full engraft after transplant do better than heterozygous. He used to say this all the time, but he never had the data to prove it. I said, "Bill, you don't have the data to prove it, but thank you on his behalf. You proved it." And I think we'd like to invite you back some other time to talk about Sanfilippo syndrome. He used to attend this meeting every week until he left practice some years ago. But back to that original question, how can one differentiate Hurler syndrome from more attenuated conditions? Any thoughts on that? That's a tough one.
Well, that is one of the key questions, and that's in fact why we don't have newborn screening in the UK. We went through our panel last time around about a couple of years ago, and they turned it down on the basis that we couldn't prove the genotype-phenotype correlations. So we said we had the data, we showed them our data, but as it wasn't published, they said, "We don't believe your data." So we're now trying to publish our data. And so when it comes to her, there were a number of, as you know, there were a number of common mutations that we see in our Hurler population. I think it's different from country to country. So I think each country will have to do this in their own way and understand their own population. But I think our data, looking at about 280 MPS I genotypes with a phenotype ascribed to them, would suggest that if we use a model of, a sort of predictive model looking at known mutations, that we can almost certainly predict a Hurler patient in well over 80% of occasions with just the genotype alone. Now, there are of course attenuated patients. The majority of MPS I patients, it's 3-to-1 Hurler versus attenuated maybe. Newborn screening may well show up a longer tail of some really attenuated patients. But I think still the majority are Hurler, and the point of newborn screening primarily is to identify our Hurler patients earlier and get them into transplant earlier. So I think genotype alone will do that in the vast majority of cases. I think there will be a few where it's difficult to know. Again, our colleagues in Amsterdam have a nice paper showing that the fibroblast residual enzyme level, is a fairly good way of predicting the phenotype. And now that's not as quick as we'd all like it, and it's a bit more invasive, but actually, if you only have to do that for the 10 or 20% you can't work out by genotype, then that maybe isn't so bad. I also think that actually if we look hard at our 2-week-old Hurlers, they're not going to be normal. We have a lot of experiences, as you do here, of seeing newly diagnosed Hurler patients, and you ask those parents, there are symptoms from birth onwards. They have a gibbous often at birth. It's just not picked up because they don't sit up. It's usually recognized when they sit up, and they reckon, "Oh, you've got a kyphosis." But it's there from birth, and the hips are abnormal at birth. I've lost count of the number of a new MPS I saw just a few weeks ago, and came in a hip spica because they had DDH. Well, no, they didn't. They had MPS I. And again, I think if you look hard, you'll find symptoms already. Is that?
It's 8:30.
Thanks, Simon. Thanks, everyone.